Hey guys, welcome back to the Foam Frat Podcast, Tyler and Sam, and we have another episode out of a series that we are doing in studio. So this one is called Procedure Preppers, and in this episode I talked to Dr. John Aho. We talk all about needle decompression, common mistakes that people make, different placements, different placement locations, and so we're going to release this. We have 3 other episodes of Procedure Preppers in studio and more to come. But Sam, you watched the episode with Dr. Aho. What were some of your thoughts?
Yeah, so this brought to light this anatomical discrepancy, I guess anatomical chart discrepancy that I've noticed over time, and I'm glad to see that other people have noticed it too. You guys were talking about the midclavicular line, and if you Google that, you get some different results. It almost reminds me of, you remember we went back and forth about like the left anterior fascicle versus a posterior fascicle. Like you look up one textbook and they're flip-flopped, and then you look up the other one and then they're the other way. And I noticed the same thing with that midclavicular line. If you just type that in Google search, you'll find some references where it has the midsternal line, like going, like bisecting left and right. And then you have the anterior axillary line kind of going down by like the shirt sleeve. And some of the charts, they have the midclavicular line that's like equidistance, like equal distance between those two. And then you look at other ones, and that midclavicular line is offset laterally and kind of lined up with the actual clavicle itself, where it finds like the middle point there. And that ends up being closer to that mid-axillary or anterior axillary line. And that's one of those things where it's like, man, you got to watch out which chart that you're looking at. When we were doing that animation for the spear from NAR, I noticed that quite a bit, that axillary line or that midclavicular line can be kind of all over the place. And that's important because you go more medial and you start running into some pretty important stuff. So that one line is like very important probably to be able to correctly assess where it is.
Yeah, I remember when Colby from Lifelink, he went down and did some cadaver lab stuff, and he came back, and that was one of the points he really wanted to stress in the procedure videos that we were making, is how far down that clavicle actually goes. Mm-hmm. And so if you're measuring in the wrong spot, that's going to completely change where that midclavicular approaches. The good news is that's not the preferred place anyway. So, if you do the 4th or 5th anterior axillary, and let's just say that the needle doesn't work a few times, at least you're in the right spot where if you needed to convert that to a finger thoracostomy, it's not like you're converting a midclavicular approach to a thoracostomy.
Yeah, for sure. And I also appreciated that point when you guys were talking about, because you've heard this thing before, and they tell you this in school all the time, that, well, if you decide to decompress someone and you're wrong, don't worry about it, because when you get to the hospital, they're going to have a pneumothorax anyway. But it was good to hear him say stuff like, well, the chances of that tensioning are probably, you're creating a hole to vent it anyway. Not that you just go, willy-nilly and everybody's getting a decompression or something, but It's good to know that probably wouldn't turn into a tension, and that the decision-making process in there is probably one of the most difficult parts, and to err on one side rather than the other. So it's good to hear some confirmation on that as well. But no, I thought it was a really good interview.
Yeah, and that process of becoming a tension pneumo is prolonged even more when you have somebody who's spontaneously breathing. Mm-hmm. They always say if you're not sure if it's a pneumo, put them on CPAP or put them on positive pressure ventilation, and it'll become a tension pneumo pretty quick. So if somebody
is that an approved rule out procedure?
Yeah, you put them on BiPAP. If it gets better, then it's fine. You were good. You don't have to worry about it. No, it was a great interview. I'm looking forward to continuing these series. I just had Cynthia Griffin on to talk about our finger thoracostomy, and we have the intubation episode that we did with Ducanto. So it'll be cool to see that series continue.
Yeah, awesome. Looking forward to the next one too.
All right, let's get right to the interview.
3, 2, 1, and action.
In this episode, we are talking to Dr. John Aho. John, welcome to the show. How you doing?
No, I'm great. Thanks for having me.
Yeah, absolutely. John, Dr. Aho, I keep saying John. What do you like? What do you prefer?
John's fine. John's absolutely fine.
John has a special interest in needle decompression, tension physiology, pneumothoraces. You've published several papers on it, and I thought this would be the perfect person to have on to talk about how to prep for the procedure of doing a needle decompression. Now, John, if you were to describe what type of patient needs a needle decompression, how would you describe that? What is the population that we're looking at?
So I'd make it in two different categories. Penetrating trauma to the chest would be one, whether that be stab or gunshot or some other type of injury that basically you think traverses the chest wall, or you have a high suspicion it traverses the chest wall. That is very high suspicion for them developing either a tension pneumothorax now, having one currently, or developing one during transport. The other category is traumatic arrest of undetermined cause, and whether that's fall from standing height, car accident, whatever. There's a pretty decent prevalence in that population of having an undiagnosed tension pneumothorax. That's why in blunt cardiac arrest or blunt traumatic arrest now, you'll typically see the recommendations to be for bilateral needle decompressions, purely as a rule out in those types of situations.
Excellent. Yeah, we at my shop use ultrasound. And so we will scan and we will look for lung sliding. And if they have lung sliding, like that's pretty good. You know that they don't have a pneumo, right?
Mm-hmm.
But if they don't have lung sliding, it's like, well, it could be pleural adhesion. It could be post-COVID. It could be that their chest is hyperinflated. There's all these other things that it could be if they don't have lung sliding. But you get somebody who lawn darted off of an ATV and they have shortness of breath and their blood pressure's dropping, okay, that makes sense. But the typical signs and symptoms that we hear for a tension pneumo are things like your tracheal deviation, which we know has a pretty low sensitivity. So what are your thoughts on the external things that we see that make us think the JVD, the tracheal deviation, that we have tension physiology?
Yeah, so as you pointed out, the tracheal deviation in most patient populations, you cannot see the trachea well, if at all, and that's a fairly late sign, even in those that you can. JVD is probably a later sign also. The main thing is high clinical suspicion, maybe having decreased breath sounds on that side, ultrasound if you have it available. But an altered chest wall movement, if you think there's some asymmetry there, or the tension, because the tension side has more air in it, they've lost that adhesion between the lung and that mechanical coupling between the lung and the chest wall. That chest wall should be bowed out a little bit more, but you may have less respiratory excursion, but the signs are very, very subtle. And so it's really having a high clinical suspicion in the field environment.
Excellent. Yeah, and we will do the ultrasound, and then if we don't see lung sliding and we suspect that they have a pneumo based off of the clinical picture, we will do a needle decompression first. And if we can't get that to relieve and they still keep demonstrating it and we're not successful, then I believe after one or two we'll opt to go to a finger thoracostomy in that setting.
Yeah, that's a totally reasonable approach. And if you're doing a needle decompression correctly and efficaciously, and say they hypothetically don't have a tension pneumothorax and your diagnosis was incorrect, the worst case scenario is you maybe gave them a small pneumothorax. You're not going to cause, life-threatening injury to that patient if you're doing a needle decompression successfully. And even doing a finger thor in the field, it sounds dramatic, but you're not going to really injure that person if you're doing that procedure successfully if you are wrong. So I think the main risk here is undercommitting in doing those procedures.
I think it's also important to note, like if you are using ultrasound and you put the probe on and you do not see lung sliding, and then you relieve that decompression or that pneumo, lung sliding doesn't just come back, right?
No.
So if you don't see it come back, don't think you did it wrong. And that can be a little confusing.
That is totally right. The idea that when you decompress in tension pneumothorax, you're deflating the balloon completely is not the reality. You're equilibrating that pleural space with atmospheric pressure. There is going to be residual air there unless you're putting a negative pressure on that. But that's something you're going to be either doing in the hospital-based setting with the chest tube or some other type of complete evacuation type of procedure. And even after you put a chest tube in, you do an x-ray right afterwards and you put it on down to water seal and suction, you still don't see complete lung expansion, immediately. Yeah. So yeah, that's a great point. You're not going to see that air go away completely after you decompress.
But you should see your vital signs get better, right?
Correct.
You should see your pulse ox come up.
Absolutely.
And those things. Awesome. With a stethoscope, how often do you think human beings can accurately detect the absence of breath sounds?
So I would say there's two different groups here. Are you on a quiet hospital ward or are you on the side of the interstate?
Yeah, well, let's put them pre-hospital. Let's say you're in an
ambulance.
In
the pre-hospital environment, we know that our ability to detect sound in those environments are not very good. That's why we use capnography or some other type of CO2 aid in endotracheal intubation. There's been plenty of instances where you think you get it in the trachea, it's in the esophagus, you think you maybe have breath sounds, but you're not sure. Maybe their vitals got better a little bit, and then over the next 5 minutes they get worse. We know that our ability to auscultate or listen for those lung sounds in the pre-hospital environment is nowhere near as good as we think it is. It's worse.
Probably just as good as checking for a pulse.
I would say that your ability to get a pulse in the pre-hospital space is probably a lot better than your ability to say, is this diminished versus normal lung sounds in a person?
Yeah.
That's my opinion.
I've had situations where we jump in the back of the ambulance, we intercept the paramedics, like, yeah, we got to decompress the left side. And I'm like, can I just take a look real quick with ultrasound? And they're like, yeah. And I take a look and we have perfectly good lung sliding.
Yeah.
And it's just that they couldn't hear it, right? Or the patient's right main stemmed. But
yeah, there's all kinds of reasons to have those altered breath sounds or to trick yourself into thinking that the breath sounds are altered, right? There's not. Our ears and our eyes trick us sometimes, and we start getting the horse blinders on and thinking that one thing is wrong, and when in fact that's not what's going on whatsoever. And it's easier in the pre-hospital environment where you don't necessarily have in every vehicle an ultrasound or some other type of those diagnostic aids. Our ability to know that absolutely attention is going on is pretty low in terms of our accuracy, I think.
Yeah, and then you're hoping you get this nice big gush of air to be like, okay, right. I was right, but we could talk about that a little bit later. That's not always going to happen. You're not always going
right.
to have the tea kettle whistle going down when you do that. All right, so let's get into the site. So there's a couple different sites that we can go to, right? We have the anterior and we have the lateral. Now, at my shop, they prefer we do the anterior axillary line, right? So you're going to go to the 4th or 5th intercostal space there. And I look at that and I think that that's interesting because that makes sense if somebody is completely is a normal body weight, right?
Right.
But when you start increasing the abdominal compartment, everything starts shifting upwards.
Yeah.
And that's
the
problem.
There's a gajillion considerations to unpack here. So you and I, when we are at end expiration, our diaphragm almost goes up to the level of our nipples. Now, that doesn't mean that, it's at the level of our nipples and it's totally flat. There's some three-dimensional thinking that's going on here, but the diaphragm goes almost all the way up to your nipples. Now, there's a rim of pleura below that, attached all the way down to that level. But your window of getting it into the pleural space and not going through the diaphragm and getting it in that little nubbin of rim of pleura, as you go lower, it gets harder and harder. The main issues or risks, there's risks with both anterior and lateral approaches, whether you're doing anterior or mid-axillary line or second intercostal space mid-clavicular line. There's risks to both of those, and the main risk with the second intercostal space is you don't go lateral enough. The clavicle is way further out than you think it is in terms of that acromioclavicular joint. So the main issue that we would see, and you see in the literature, is people go too medial, and they end up being medial to the nipple Well, if you're medial to the nipple, you're now in the trauma box of all of the important structures of, great vessels, cardiac structures, etc. Main risk going laterally is you go too low. You have that thin rim of pleura because they're at end expiration, because nothing is mechanically working, or maybe they have a pneumo on that side and it's blown up a little bit, but you still don't have this much space to get your needle in the right location. So people go too low laterally and people go too medially anteriorly. And there's also logistics considerations too, right? If somebody's strapped to a backboard, how do you realistically access that mid-axillary line or that anterior axillary line reliably and know that their armpit is way up, their axillary fold is way up there? So there's problems with both, and being aware of those problems avoids, the main risks, which anteriorly, you can't go medial to the nipple. Laterally, you should not be going, lower than the inframammary fold. And that's a pretty well conserved structure, is where that skin and skin meet if they have breast tissue. Do not go below that inframammary fold and you'll be reliably safe.
If you had a patient that was morbidly obese, and you had to perform a decompression because you thought that they were having a tension pneumo, do you think it makes sense in that situation to use something that has a blunt tip like a finger to do a finger thoracostomy, and maybe start off with that instead of doing a needle, and then if you fail that, moving to your finger? Do you feel like...
So in my personal opinion, I don't think so, because the structures that you have the most variability in are skin to chest wall. Like if they're obese in between the skin and the chest wall. They're not thick in the chest wall itself. And putting in a chest tube in a large person has this, and finger thoracostomy is like 95% of a chest tube, right? And so getting your finger, if my finger's 5 centimeters long, but it's somebody obese, I am going to have to work to feel that inner space. I'm going to have to really crush that chest wall with my hand to know that I've really got into that pleural space successfully. And the other consideration for finger thor is if you stick your finger in a pork roast or something and you take your finger out, what happens to the tract? It just collapses. Same thing when we take chest tubes out of patients in like after some type of thoracic procedure. You take the chest tube out, you don't actually close the hole with sutures. You let the hole collapse on its own. So if the transport is short, I think that would be a reasonable approach, would be finger thor, but I'd be worried about that tract collapsing, not having something to prop it open. They would reaccumulate a pneumo because they have some type of air leak from their lung parenchyma or a larger airway or some structure in there. I'd worry about them retensioning. The other thing is, now you've made 2 holes. We know that patient's going to need a chest tube, and you can't use that same finger thoracostomy hole for the chest tube. So, because
you can't. I didn't know that.
I would definitely not advocate for that, because that would be considered a contaminated hole afterwards. I would in that situation, I'd probably use like an 8 centimeter long angiocatheter. I'd bonk it into the rib, and then once I know that I've touched the rib, now I have 3 more centimeters to go on average to get it into the pleural space. But obese patients present the problem, but they are thinner laterally, despite what and that's what the data would support, is anterior axillary line or mid-axillary line laterally for somebody obese is probably my preferred go-to. But I don't think I'd do a finger thor unless I were, in the trauma bay and I was doing a chest tube, but I would do that as a component of the chest tube procedure. So the long story short is I don't think so, because you have the same issue. My finger is only 5-6 centimeters long. I cannot get into that pleural space to know that I'm in the pleural space correctly, successfully, and that decompression is not a durable decompression based on the Australian data, where they have longer transport times than we do on average. I think that's problematic no matter what you do, but I think if I were in the pre-hospital environment, I would do a long needle D in that situation.
Yeah, no, that totally makes sense. And, you were talking a little bit about the placement of those. The way we do that with the spear needle is, and we were talking a little bit about this yesterday, is we actually use that needle as a scalpel, and we cut against the rib, obviously, if you can get to it, if there's not that much adipose tissue. But we want to feel that rib, and we go into that rib, and then we measure back 3 centimeters once we hit the rib, and then we will slip up and over the rib
Yep.
at 3 centimeters, and that's where the needle stops. Right, we don't keep advancing the needle. Then we just advance the catheter off of that, withdraw the needle, and then there's a little whistling thing you can put on there at the end once it comes off, and it's got that one-way valve on there. Is that similar to how you typically do it?
That's pretty much exactly what I would advocate for. I know people say that you can feel the pops and all of this. Like maybe in a non-bumpy, non-austere environment, can you feel the pops of going through the intercostals and the final pop of going through the pleura? If the needle is sharp and you're doing this procedure under actual clinical conditions, I personally don't think you're going to feel those pops very well. And a lot of people aren't doing the nick and they're tethered at the skin. If you're tethered at the skin, I don't think you're going to feel the pops super well either. So yeah, but you basically hit the nail on the head. I personally think you should hit the rib, and then you actually know, okay, I'm almost to the pleural space. I need 3 centimeters more. I know some people out there will advocate for hub the whole thing. I think that's a risky maneuver, particularly with the longer angio catheters, particularly if you're going laterally, and particularly if you're going on the left side, because there's cardiac structures under there that's high rent real estate with an 8 centimeter catheter. And there's good data out there that an 8 centimeter laterally and hubbing it, you're likely to hit cardiac structures.
Where did they come up with 3 centimeters? Is that like an average of how far from the ribs to the pleural?
So NAR had data that they measured. I think it's like 2 centimeters and some change. I'd have to go look at what their white paper says, but they basically figured out that people have known this for forever. Like you get thick in between the skin and the musculature. People tend to be thicker, in between skin and musculature, and that is where they figured out that there was the real variability based on CT scan data, other works that are out there in the literature, that people pretty well conserve the distance between, say, rib out external intercostals all the way down to the pleura. That distance is actually pretty well conserved. So if you look at 2 centimeters, but you're going at an angle, it ends up being about 3. And so that's basically how they came up with that data.
Now, it's super interesting. If you were teaching paramedic students and they haven't done this yet, and they're like, what's the best way to practice so it actually feels real? I know the mannequins have gotten, a lot better over the years. But what do you think is the best way to train on this and to practice so you get that muscle memory, that textile feedback of actually performing the procedure?
If available, cadavers, but those are expensive. They're hard to find. Those opportunities are few and far between. So human cadaver torso would be the most ideal situation in terms of practicing. But absent that, and you don't have $20,000 for a cadaver, I think the mannequins are decent. I think there are, the tissue quality on those simulation mannequins has come quite a long way. The one thing I think that's worthwhile noting about the mannequins is that the pleural pops are sort of artificially amplified on some of those in terms of, okay, you've felt this pop for teaching purposes, of course, you felt these pops, and then you feel the final pop and you're in the pleural space. People are a little flimsier than that on the average, especially if you're using a sharp needle. In terms of getting that pleural pop sensation, though, with real tissue, you can go to the butcher. I mean, people eat pork ribs pretty consistently. Just see if the abattoir, the butcher will put together, a pork wall for you, or, a side of pork, or maybe you're doing a pork like a whole hog or something like that. And get the sense of what that actual tissue feels like. The silicone and the other simulants have come pretty far along, but if you're going to, have a whole hog roast at some point during the summer, maybe get a feel of what that actually feels like. And note that the skin is thicker, of course, on a pig, than a human, but that pleural pop, the fat texture that's all pretty comparable. And that's why we use pigs for pretty much all of these needle decompression animal studies. It's pretty accurate compared to what we have as a human, but it's not a human.
When people are performing the skill and you've seen them, in your practice and stuff, do you identify certain mistakes everybody makes or they're easy to make? What are some of the common
Absolutely.
pitfalls?
Well, you got to prep the skin, do all that stuff. People get that part pretty much correct. The main issues are what I'll call two-dimensional reasoning problems and then three-dimensional reasoning problems. There is the main tendency, if you're going anteriorly, is people think the clavicle is, this long on their chest. No, you can feel your acromioclavicular joint way out here. The midpoint of that is always lateral to your nipple. Always. Like, zero excuse to be medial to the nipple. Sternal angle of Louis on bigger people is a little harder to feel, but there's still a bump there. And so you draw that line between the two, and that line where those two lines intersect, that point, that needs to be lateral to the nipple, period. Otherwise, you've done something wrong. The other mistake I see is one I alluded to earlier. People think that the chest ends at the end of the ribs. It does not. The diaphragm is a curved dome, and people need to think of it as a curved dome with more curvature than they appreciate. You almost always need to go higher. If you're immediately below the axillary hairline, you're probably in the right spot. You should never be below the inframammary fold. You're going to end up with a liver biopsy or a spleen biopsy or a heart biopsy. You need to be way higher than you think for the lateral, way more lateral than you think for the anterior approach. Those are the two main mistakes are getting the surface anatomy wrong. And then people have a tendency to think of humans as a box. We are not a box. We aren't, Minecraft people. Like, we have curves. So your chest wall curves and your chest wall flares. So imagine you're trying to stick this into a 2-liter bottle. If your angulation is not perpendicular to the bone, you are going to skive in either direction, and that's going to make the distance higher to the pleural space.
That's a really good point. I remember hearing that, like, when you think of mid-clavicular, you always think like, oh, right here, right? That's got to be like right at my nipple line. But then you actually
and then you're putting the needle in this direction, and you end up in their armpit, right? As opposed to going, you need to go like perpendicular to the chest wall, not perpendicular to the skin.
So, Dr. Aho's sitting in the OR, and he's thinking about, maybe you're watching a needle decompression, and you're like, you know what? You don't always get that loud gush of air that comes out, and you're wondering, is there a way that we could get like instant feedback that we have actually done this successfully, right? So
we had that exact problem.
Yeah.
And we saw needle decompression has somewhere between a 0 to 50% failure rate. Most studies you look at are somewhere between 10 and 40%, 20 to 50% ballpark. And you don't really necessarily hear the gush of air in the pre-hospital environment. And if you do, it's very short-lived and you're not confident in it. And so what we were noticing were patients would come in with, 2, 3, 4, 5, 6 needle Ds. And we said, well, how can this be? What happens is you get a coin flip problem, right? If you're 50% right, 50% wrong, and the patient's not getting better, you put another needle D in. Same thing, you get on this hamster wheel of, well, something is wrong, maybe our needle D didn't work, let's put another needle D in. And we were sitting there wondering about that. And that's sort of how we got down this path of, do you use a 5-centimeter cannula? Do you use an 8-centimeter cannula? Do you go anterior? Do you go lateral? And we studied the heck out of that. And it didn't actually seem to meaningfully influence the decompression rates that we were seeing. And we said, well, we basically asked around to the paramedics, we said, what's the issue here? And they said, we have no idea if we got it in or not reliably. That gush of air is something that, somebody came up with on some quiet hospital ward, not on the side of I-90. And they're right. Like, that is a hospital-based standard that then got applied to pre-hospital EMS. It's not, it's not one to one. Those two environments are
Right.
very different
Or the
environments.
syringe with the bubbles and
Yeah,
stuff.
and
There's
there's all
been all
kinds of
these.
like jerry-rigged solutions out
Yeah.
there. I cut the tip of the glove and I tape it to the cannula and I make a little flutter valve and all kinds of shenanigans
Whistles.
like yeah, all kinds of shenanigans like that. And we said, well, what can we do that would make a reliable indicator that the thoracostomy or needle D is functioning correctly? We came to the fortunate conclusion that these pneumothoraxes have CO2 in them. The CO2 makes it so that the air is, more like air you breathe out than air you breathe in. And we already have, technology that we use every day in pre-hospital medicine for detecting CO2, colorimetric paper, quantitative waveform capnography, things like that EMS is already familiar with. So we said, well, can we just use colorimetric indicator paper, bolt that onto the end of whatever angiocatheter these guys are running, and then they know if they did the procedure correctly or not. It ends up that it works just fine. We did animal studies that show that the sensitivity and specificity are much higher and near perfect compared to operator expert judgment, which as we well know in the pre-hospital space has you don't want to trust human judgment. You want to trust something that is reliable and objective. And so you basically bolt this little capsule onto the end of the angiocatheter on the Luer lock fitting, of course. It's called the capno spot. The FDA cleared it with what's called a superiority claim, which is it is more accurate than using a gush of air and measuring vital signs for knowing that you've treated a tension pneumothorax correctly. So yeah, we're selling it into the space. Places all around the country are now using it and or having it on trial for major metro areas. And we've had success stories both in air ambulance and ground ambulance, and people are loving it because the gush of air is honestly bogus.
And we can take all the colorimetric devices for end-tidal CO2 for ET tubes and convert those over to something that's actually useful, like the capno spot.
Yeah, right. Yeah, and so like you can buy them from whoever or use them from whoever or train on them. It's the same training that you had for the colorimetric indicator paper, same color change and everything. People already know what that means for by and large in EMS.
If it reoccludes, will it go purple again?
Yeah, it'll shift back to blue over the course of about a minute. So I didn't see the value in that initially, but in places where they have longer transport scenarios, they're trying to troubleshoot a cannula, or on a helicopter where they can't hear really what's going on with the cannula, or just take their headphones off and lean down to it. They thought that was great because I thought it going from blue to yellow was great. But they actually thought that when it goes from yellow back to blue, that's when it actually matters for them, because then they know that they need to put another catheter in or an angiocath.
Yeah, I think that's a phenomenal idea, because we were talking about how you can't count on lung sliding returning.
No.
You may not hear the rush of air. They've tried to put whistles on some of them, and I actually did hear a whistle one time, so that was cool. And you're looking for vitals to return.
Out of curiosity, what's your sense of the number of needle Ds that you hear a gush of air or a whistle if you're using the duckbill valve? Is that a 1 in 10 phenomenon, a 1 in 50 phenomenon, where you put the catheter in and we heard it, no question, boss? Like, what's that like?
God, so I've been doing this for 13 years now. And so it's a little bit, you're not doing needle decompressions every shift. Since I've started flying, I've done a lot more. I would say maybe 25% of the time.
I would say that that's about what we're hearing from people is they say, some people say I hear it every time, and I'm pretty confident that they're a fibber magoo if they're telling me that. But, yeah, right. But I think somewhere about 10 to 20% of the time when they actually have a tension pneumothorax, are you actually hearing it? And it's definitely not, you're going to hear a gush of air and the vital signs are going to reverse in the next 10 seconds. And that doesn't work like that.
Well, and here's my my little hang up with the vital signs returning is typically these are trauma patients, right? So there's nothing saying they don't have a pelvic fracture and a pneumo. You're waiting for that blood pressure to come back up or the pulse ox to come back up, and they're hypovolemic and hemorrhaging. And you want to know at least you checked this off, right? And even if they did have a pneumo, this looks good. But if you're waiting for everything else to come back, if it's just a pneumo, yeah, it should. But,
but
how often is it just a
yeah,
pneumo?
in
You
our
know?
population, like in Minnesota, that's not the case, right? Like if they have blunt injury and they have a tension pneumothorax, they almost guaranteed have, a splenic fracture or a liver laceration or, a hemopneumothorax on top of it or an underlying pulmonary contusion and, a chest wall that is crushed. There's a bunch of other injuries that are always going on with these patients in addition to the pneumothorax outside of, say, an isolated penetrating stab wound to the, lateral aspect of the
Right.
thorax. Almost always they have other injuries that can cause those vital sign aberrations.
So it's like it's great if it does return, but if it doesn't, that doesn't necessarily mean you failed your decompression. You could have
No, it
done that
absolutely doesn't.
decompression correctly.
But there's a tendency to tunnel vision in on, oh,
Do
I
another
think
one.
yeah, right. Like, okay, I think he's got a tension. We did the decompression. Did the tension work or not? I didn't hear the gush of air. Okay, well, let's do another needle D, when they could have gotten, an IO or a second IV or something else and started running blood or fluids or whatever for their location. I think that tunnel vision thing is real.
And just to clarify, you didn't come up with a needle. You came up with an attachment
Yeah, so
for the
whether they're
catheter.
running a North American Rescue Spear, an ARS, an enhanced ARS, a TITEC, a pneumo dart, an H&H, a regular 14 or a 10 or a 16, 18 gauge angiocatheter, doesn't matter. It'll connect to all of them because it uses the same lure fitting. You put the thing on.
Do you have one by you somewhere?
Yeah, I do actually. Give me 1 second. I'll go grab one. Give me 1 second here.
Do a couple pull-ups on those bars too while you're back there.
Oh, so those are totally for show. Yeah, so they come in a little foil pouch. They have to be in foil because it's got that capnography paper stuff
Yeah,
inside of
that makes
it.
sense.
Got a little label on the front. Has a little instruction guide on the back.
Oh, nice.
And then, they single use, disposable. You can use the same one if like say you have one that's in the patient and your cannula, shifted it back to blue, you can use the same one on the second angio catheter. That's fine. They're blue, but then when they get exposed to CO2, they turn yellow.
That's awesome.
Changes in about, we say less than 10 seconds, but it's like 2 to 4.
Man, that's super cool, dude. I can't believe I didn't think of that. That's what
Yeah.
everybody says about all the
We've
good
gotten that a
inventions.
few times. And it's not something you need every day because, like
No.
you said, it's the number of needle Ds that we do is, I don't know, once a month maybe on a provider basis, but for like a really busy place, and that's another thing is we don't do these as often as we should for, say, blunt traumatic arrest. We know that we're under decompressing those on the average in the nation. We know that if you don't decompress, the patients do poorly. And that does happen in different EMS agencies across the country. Is they don't have confidence in that skill because the last time they did that skill was either training maybe months and months ago on a human in a clinical scenario. Last time I did it was an ATLS when I renewed my ATLS 2 years ago, right? Like that's a infrequently used skill, and that's exactly what you need, these aids for, get the 2-dimensional anatomy right, get the 3-dimensional anatomy right, get the procedure done correctly, move down the algorithm and how to take care of that trauma patient.
That's awesome, man. Well, John, thanks so much for coming on the show, man. I think this will be a really good episode. Lots of information that we covered, and wish you the best with this, man. I'm excited
No, I
to see more of
appreciate
the
it.
experiments. Let me know when you make this glow in the dark, and we can do another episode on it.
I appreciate you, and let me know if I can be any help or you need anything in the future. I'm happy to talk on whatever topics you want.
Awesome. Thanks.
Okay, talk to you later.